And this is an example of a patient with non-small cell lung carcinoma. On the upper left, you see a MIP image from a PET scan that shows the FTGI avid tumor in the right lung. On the other hand, the CT image in the middle on the right shows the pancreatic head in great anatomic detail, which we cannot appreciate on PET. And we can even see the small punctate calcifications, which of course are not visible on PET and actually are also not visible on MRI. But that tells us this is a patient with chronic pancreatitis. Another great advantage of CT or strength is in evaluating for lung nodules. And one of the reasons is that soft tissues against a background of air density stand out extremely well with CT. And so very small nodules, 1 or 2 millimeters in size, are easily picked up with CT, whereas we have almost no chance of seeing those with PET imaging, where we have significant problems with partial volume effects. Notice on the right, there's a deep inspiration breath hold CT scan with low-dose technique that was obtained as an adjunct to the PET CT scan. And this is a great way to enhance your PET CT scan to optimize the evaluation for lung nodules that might be missed because of their small size on the PET. So why not do PET CT in our initial workup of a pancreatic cancer patient, since pancreatic cancer is often FTG avid? Well, one reason is that other things are also FTG avid, like pancreatitis. And also, PET, of course, lacks the anatomic detail of CT, so we will not be able to make judgments about resectability on a PET scan. In this example of the same patient that I showed you earlier, again, on the bottom image, this is a contrast-enhanced CT that's performed as part of the PET CT scan. We see the subtle hazy tumor infiltration in the fat around the SMA, but on PET, there's no way we can appreciate that. We do see the FTG avid lymph nodes in the root of the mesentery on PET, but we also see those on CT. In the liver, the same patient, we see FTG avid liver metastases, and we also see subtle metastases in the liver on CT, the contrast-enhanced CT. Notice that some of the larger metastases in the liver that are FTG avid are not visible on the CT. Those are isodense metastases. On the other hand, some of the smaller metastases that are visible on the CT scan in the liver are not visible on the PET because of the partial volume effect. So they're kind of complementary in the liver. We still use CT in the initial workup of these pancreatic cancer patients because we have to have that anatomic detail to determine resectability. Another patient with pancreatic cancer, we see the FTG avid tumor in the pancreatic head next to a plastic stent in the common duct. But notice that in the pancreatic neck and body, there's another area of FTG uptake that actually turned out to be ERCP-induced pancreatitis. So that's the problem with nonspecificity.